My name is Dr. Sarah Fitzgibbon. I'm the founder of the Women in Medicine in Ireland network. So WIMIN is an organisation that aims to support, encourage, promote female medical students and doctors in Ireland. That's its main aims. So it actually started, it's set up in 2017, the end of 2017, and a couple of things prompted me to set it up. The first was a conversation that I had with two friends of mine who were both consultants in different hospitals in Ireland, and the three of us met up one day for coffee, and the two of them ended up having quite lengthy conversations about experiences that they had working as consultants in hospitals, talking about where they would be in fairly high level meetings or decision making fora, and things like that they would make a suggestion which wouldn't necessarily be heard or listened to and would be maybe ignored or brushed over. And then 10 minutes later, a male colleague would make the exact same suggestion, and then suddenly it was a great idea, and suddenly this would be taken on. So my first friend spoke about an experience like that, and then my other friend said, yeah, that happens to me all the time. And I was a little bit surprised by this, and I asked them a little bit more about their experiences that they were having as consultants in hospital. And they spoke a little bit about either witnessing or being having personal experience of what might be called maybe sort of minor sexist comments, or things that would be maybe passed off as jokes. I suppose experiences that most women would be familiar with. But they spoke a little bit about the demeaning nature of that when they were in, we'll say, positions of authority or power, and how that was tended to sort of, I suppose, diminish their status, we'd say, in a group setting. And they also spoke about, we'll say, in a theatre setting where instead of male and female changing rooms, that there would be doctors and nurses changing rooms. And I assumed the last time I'd worked in a hospital would have been 15 or 20 years ago. And I assumed that all of these things would have changed. I imagined, for whatever reason, that none of these things were still happening. As a GP, I'm self-employed, I'm working in a partnership setting, I'm not working in a large organization. I don't experience those kinds of microaggressions in my own life. And so therefore I thought they didn't exist at all anymore. And yet as I listened and I learned more from my two friends, I began to just question a little bit more and maybe look around me a little bit more. And that made me think a little bit more about these issues. And then the next thing that happened was that I heard about the Medical Women's Federation in the UK, which would be a similar organization to WIMIN, but it was founded 100 and something years ago now. And so some of the very first pioneering women in medicine back in the 1918 had come together to form this organization. And I thought, well, we don't seem to have anything like that in Ireland, and why not? And I just put it out there on Twitter, on social media, to see if anybody would be interested in something like that. And I got really positive feedback from a lot of different women, and lots of people very keen on exploring the possibility of something like an organization specifically to address the issues that are relevant to women in medicine. And then I guess the third sort of thing that came together within a couple of months back in 2017, I myself had been diagnosed with stage 4 bowel cancer back in 2014. And I'd been really lucky in that my treatment had been very successful. And I was more or less, we'll say, coming out the other side of treatment at that point. And I suppose I sometimes call it my Oprah moment. It was sort of where I kind of felt, well, I've been very, very lucky having come through something that I mightn't necessarily have come through. And I guess it was my time to maybe give something back, or to maybe use my energy and use my focus in a way that was going to have a positive impact on other people. So there have been quite a few proud moments. The first would probably be our first conference, which we held in March 2018 in Dublin in the Macro Hotel. And I really had no idea how it was going to go, but around about 100 women arrived at the hotel, and it was just an amazing energy. There was such a diverse group in terms of, there was a mixture of students and trainees and consultants, GPs, professors, a senator, retired senator, and it was just a lovely, warm atmosphere with lots of sort of cross-collegiate chats and support amongst everybody. We had our second conference in Cork in 2019, which was also a great success, and we were due to have our third in Belfast in March of 2020, but unfortunately that has been postponed, hopefully until March 2021. And the other, I suppose, proud moments, we WIMIN as an organisation sponsored some football jerseys for the under 13 Avondale United girls soccer team, and they went out in their WIMIN jerseys with the WIMIN brand on them, and they won their match. I have to say that was a lovely sight to see 11, 12 and 13-year-old girls with their WIMIN symbol on their front and playing their little hearts out. So that was lovely. And I guess the third proud moment would be I attended the Medical Women International Association Centennial Congress again in July of 2019. So that would be the international umbrella organization for all female doctor organizations around the world. And that was held in New York, and there was, I think, maybe 500 or 600 delegates from all over the world, from every continent. And at that Congress, WIMIN was then formally affiliated into the MWIA. Yeah, so when we're looking at healthcare for women, again, bearing in mind that nearly all research for the past 70, 100 years has been based on the norm of the male body. So much of the research that would have been done would have been, we'll say, if they're drug testing or testing a particular therapeutic intervention, it's always on young men. This is the, I suppose, process that would have been gone through for many, many years. Part of the idea of that was that it would be dangerous in some way to be experimenting, for want of a better word, on women of reproductive age, and potentially looking at the effects of medications on the teratogenicity or the affecting the fetus if a woman was pregnant. At the same time, that means then that there has been no research on what might happen if a woman was pregnant when a medication was given or when a particular intervention was carried out, which has then resulted in this idea of women who may or may not be pregnant being excluded from any type of trial or any type of new intervention, or being told, we don't know what will happen, you have to take the risk yourself. Or that as a GP, if I'm prescribing something to a pregnant woman, I can say that it seems unlikely that this will cause you any harm because this many women have taken it anecdotally, but there isn't any proper solid case control research done on this particular product for pregnant women. This also affects women in relation to when you attend for healthcare in a hospital. So as a patient, this is something that I would know, the endless questioning about your last menstrual period. Are you pregnant or not? And simply saying no doesn't seem to usually work. And does that come down to, how do you know whether you're pregnant or not? Or this sort of slight patriarchal, well, that woman wouldn't know if she was pregnant, so therefore we must do a pregnancy test, or we must get her to specifically give us the date of her last menstrual period, as if women's menstrual periods were all the same, and as if that had any reflection on her fertility levels or in anything else. So it's almost a slightly sort of belittling or demeaning process that each woman who enters the hospital system has to go through over and over, regardless of whether or not they've had sex in the last 4 weeks, which is probably the most relevant thing to whether they're pregnant or not. And so that would be one aspect in terms of women's healthcare. There would be, I suppose, a belief out there that potentially some of our systems, some of our maybe structures that have been in place for some time, because they were put in place by mostly male doctors, we'll say 20 or 30 years ago, that therefore they might be inherently biased against women. I'm not 100% sure on that, because we know that while there have been male leaders in medicine for quite some time, we also know that there has been a significant number of women in medicine in the background doing a lot of the background hard labor for quite a long time, and their influence shouldn't be underestimated. So this idea that there has been this very strong male leadership without any female influence, I think is probably not massively accurate. When you think about it within the HSE, something like 80% of HSE employees are women. It happens when you look at the top layer, in the leadership layer, and that is where you have this, glass ceiling effect, or the effect where the men sort of rise to the top by virtue of their maleness, and the women tend not to. And obviously, this is going to affect high-level decision-making, but as I say, we shouldn't underestimate the influence of those 80% of women who are doing the hard work, and they do have influence. We need to get it stronger. We need to get their voices out there. We need for more voices to be heard. I think the number one thing is to call it out. So when we see it, to have the support of each other to be able to call it out. One woman, complaining about perceived bias can sometimes be gaslighted, is the term. So where she's told she's wrong, that your experience is wrong. You think that I'm bullying you, but you're wrong. And if there are 3 or 4 or 20 or 500 women saying these are our shared experiences, it makes it much harder for it to be turned back around to us and say you're all wrong. So it's, I suppose, what you might call the Spartacus effect. We all stand up and say these are our experiences. And so when we see it, to call it out. One example of that would be, more recently it has become more difficult for organizations to present a panel at a conference, so a panel of experts who happen to be all male. And in the past, that would have passed without comment. It would have just been, these are the men who know the most about thoracic something or other, therefore they are the people that we will hear from. Whereas now we are able to say that is not accurate, that is not representative of the people either that you're working with or working for in terms of your patient group, and sort of demanding that there would be a change in that. So not supporting organizations that produce a manual, that will have not attending conferences where there is very, very obviously a lack of diversity. And again, so the diversity comes down to also in terms of race, in terms of ability, in terms of maybe gender identity, all of those kinds of things. And the default, as I say, will tend towards the male, pale and stale, so the older, middle-aged white men, and there is no need for that. That is just default thinking. That is just, this is how it's always been done. There will always be a woman who is expert on an aspect of the topic that you're talking about. It might mean that you need to look a little bit sideways rather than just at the pile of your usual people that you call. If the woman is unable to attend, unable to participate, it's important to find out why. What is it about your organization? What is it about your event that makes it more difficult for women to attend? At women conferences, we have been able to provide childcare. It's becoming a little bit more common in other conferences, but still it's a novelty, and the conferences that do offer childcare will use it as a promotional tool, and that needs to become normalized.